Okay, hello everyone. Thank you for joining another APP education series. The topic for today is syncope for the hospitalist. So, how to approach syncope? Our learning objectives for today is to uh, learn evidence-based syncope management and approach the management of vasovagal syncope, orthostatic, and cardiogenic syncope. And I'm sure all of you do plenty of admissions, cross cover related to syncope. So hopefully we can tackle that today. And the goal of this talk to be as interactive as possible for you to like benefit the most. Feel free to participate either by unmuting or putting in the chat as we solve through the cases together. So the first case is we have a couple of cases that I want you all to think through. And after this slide, we're going to through like what workout would you want? So these are all like cases that I have seen over the years. So this one is an 80-year-old who stood up to work with physical therapy, lost consciousness right there, had jerking movements afterwards of the upper extremity. Then they put him in bed, checked his blood pressure, and the blood pressure was low, but then it resolved. The second one is an admission of a 55-year-old who had a car accident. And then on exam, they noted a tongue laceration. And then the third one is an 88-year-old who was admitted from trauma for a ground level fall. And he was found on the floor confused. So the thing I want you to think of is this syncope or is this a mimic? And then after that, I'm going to give you a menu of options for all these patients. So do you want a EKG, head imaging, a carotid ultrasound, an EEG, telemetry, orthostatics, an echo, a CTPE, a Holter monitor or a loop, and what do you think is causing all of this? So I'm just gonna pause for like a minute just for y'all to think through this, and when we can chat about it in a little bit. All right, so let's go through these cases, and you don't need to share right now, but I just want you to hold on to your what workout you would do for these patients, and then we can go through the thought process and the explanation. So just going through syncope in general. So what is syncope? So it's a transient loss of consciousness due to cerebral hypoperfusion. And I use this schema for syncope, which includes reflex. The big buckets include reflex syncope, which includes vasovagal, orthostatic syncope, and cardiac syncope. And before you even think about syncope like differential, you want to think of syncope mimics. So is it a ground level fall? Is it a seizure? Is it a stroke? Is it hypoglycemia? Like, is this even syncope at all? So a lot of times seizure and syncope can be very, very similar. So how can we compare the two? So turns out that jerking movements can occur in both syncope and seizure. So they can both have jerking movements of the extremities. In seizure, it's more likely to be prolonged and more likely for you to be post-ictal, especially if it has a generalized seizure. While with syncope, convulsions are common. So you commonly have shaking movements. They usually last less than 10 seconds. You usually are not altered after you lose consciousness for a brief amount of time and you have a rapid recovery. You're like, okay, how else can I differentiate? So prolonged confusion is usually more common with a seizure. And the best test to like think of, is this a seizure, is if you have a tongue laceration. So if it has a lateral tongue bite, then it's very like predictive that this is a seizure instead of syncope. Okay, what about urine or stool incontinence? Turns out that urine and stool incontinence occur in both seizure and syncope. So you can differentiate just from having tonic movements, urine incontinence, stool incontinence. You can differentiate between syncope and seizure. And just how to think about seizures in general is seizures can be focal or generalized. Focal seizure is you don't necessarily have awareness to it. It's a very specific part of the brain. You don't necessarily lose consciousness, and usually it does not generalize, and usually you're not altered after. A generalized seizure happens when you have like a generalized tonic-clonic seizure. Sometimes you don't have these movements, but usually you're lose consciousness, you're confused for a prolonged period of time, or you're post-ictal. Now, a lot of times we get EEGs and the EEG does not show any seizure activity. Does that mean that the patient had a seizure or not? And an EEG is only in one moment in time. So if you get an EEG and it's not showing seizure, it does not mean that the patient did not have a seizure previously because it only captures that moment in time. Sometimes it can show like a focus of activity, but for the most part, it's to capture that moment. So the diagnosis a lot of times is clinical, like who witnessed it? Was there anybody take it? Did anybody take a video of it? Can you describe it? And that will help you like diagnose seizure first and foremost. So patient comes in and they had this like loss of consciousness. You're not sure, should I order an EEG? So you would reserve an EEG only if the history is suspicious. So if they have like all the features we described before, if they bit their tongue, if they have like history of brain lesions, or if they're persistently confused for a prolonged period of time. That's part of my workup. If they don't improve, then could they be having like non-ictal seizures? Sorry, seizures without like tonic-clonic activity. So, anybody want to guess what the first case diagnosis was? And feel free to unmute or put it in the chat. Yeah, awesome. So we see a vote for orthostatic, and that is like the big clue here is that the blood pressure was low afterwards. And the thing to like what we just learned is that, oh, you can have jerking movements even with syncope. So this was an orthostatic syncope case. And then anybody want to guess the second one? Okay, seizure, exactly. So like we just learned, like if you have a tongue laceration, the pretest probability goes up for seizure. And anybody want to guess the third one or what's your best guess? Yeah. So it's like, is this a seizure? Is this cardiogenic? The answer is we don't know. And the answer is like we should not be labeling this as syncope. Yeah, exactly. It's like they were found on the floor confused, but could we even call this syncope? So I just put this there because we get a lot of admissions that are quote unquote syncope. And a lot of times, if it's a case like this, I always end up writing question mark loss of consciousness, question mark altered mental status. I don't even know if this is syncope for me to like have a differential diagnosis for syncope. So like you're all saying, I would want more information, but I would primarily think of this as like delirium, confusion, what's going on. So in terms of workup, before I reveal like the answers or what I think we should work up, anybody wanna unmute and share what would they like? Let's say this they had this patient with them. What which of these options would they get for this patient?
Orthostatics to start.
Okay, okay, awesome. I love that. Anything else you want on this menu?
EKG.
Okay, good. Anything else?
I do probably telly as well.
Okay, okay.
I know the
That's
ED would probably already have gotten a head CT for us.
okay. No, but this happened on crossover.
Oh, okay.
Would you get it then, or you think maybe not? It's up to you.
Um, no, I would first want to do like a neuro exam and assess their mental status.
Okay.
And I think that would probably be a test that I would hold off on,
Yeah,
if
yeah.
their mental status is intact.
I love it. So I agree. So would get an EKG for sure. Head imaging, like probably not unless they have like a deficit, they hit their head. Carotid ultrasound, no. EEG, no. Tele plus minus, like you could get it. Orthostatics, definitely. CTE, no need. CTPE, no need. Holter loop, no need. And we thought this was orthostatic. Second one, we thought it was a seizure. Uh, similarly, we said we would get an EKG almost on everyone. Head imaging, especially if it's a new seizure, you would want head imaging. And then carotid ultrasound, probably not. EEG plus minus. So again, the EEG will diagnose it if they're seizing right now. Let's say they're back to baseline now. I wouldn't necessarily get an EEG unless neurology wants it or they're persistently confused. Telemetry plus minus, like he doesn't really need it, but it's not like completely wrong if you're like, oh, could this be cardiogenic just because uh, I don't know if they were exerting themselves or what was going on. And then the rest would probably not. And then the last one we're thinking maybe is delirium. So we just need more information to see what's going on. Uh, I'm gonna jump to the next case. So 78-year-old male with diabetes, hypertension, had syncope while having a bowel movement. So the question is, what's the cause of syncope and would you obtain a carotid ultrasound? If anybody wants to share, feel free to unmute or put it in chat.
I'm leaning towards vasovagal with this one and would probably not do a carotid ultrasound.
Awesome. So vasovagal, no carotid ultrasound. So we're going to the first cause of syncope, which is reflex syncope, which includes carotid hypersensitivity, situational syncope, vasovagal syncope. So these are the three like settings, like vasovagal, situational, and carotid hypersensitivity. I found this like hilarious doctor on Instagram who like does educational videos, and apparently she acts out the syncope maneuvers. This was one of the. This is the actual like doctor passing out on the bathroom, but yeah. So a lot of times in vasovagal syncope, history is key. So it's all about hearing that prodrome, the triggering event, having the symptoms that you feel before they're happening, like palpitations, anxiety, sweating, and then after that, feeling this like parasympathetic surge, the warmth, the nausea, vomiting. And if any of you have had a vasovagal in the past, you will know what it feels like. I've definitely had it. So uh, it's very much on history. Now the question is, when do we get a carotid ultrasound in syncope? Before I tell you, I want you to lock in your mind when you would order it, or what would you be your threshold to order it. I'm gonna give you like 10 seconds. You don't have to share it with the group. All right. So carotid ultrasound in syncope is one of those things that we do for no reason. It's for the vast majority of cases, it's low value care. So you should only obtain a carotid ultrasound in syncope if they have a focal neurologic deficit. You basically thought that they had a stroke, or they have a carotid bruit. And so these are the only two indications. And the main reason for this is that carotid stenosis on its own will almost never cause syncope unless you have like a stroke or a carotid steal. So for me personally, I think I've never ordered a carotid ultrasound purely for syncope. I order it mostly for like stroke workup and for that reason, but otherwise, it's not indicated in syncope. So, like you all said, vasovagal and no. So, going over to the next case, a patient had a fall during a hot shower, and you check the orthostatics, and these were the orthostatics. So they were laying in bed, 140 over 80, heart rate 90, and then they stood up, and it's 110 over 50, and heart rate 120. So what would you all do next?
Just the only thing that's coming to mind for me right away is looking at MedList for Beers criteria meds.
Yeah, I love that. So your patients are orthostatic. You want to like review their medication list to see if anything can cause them to be orthostatic. Awesome. So orthostatic vitals are defined as a drop in systolic more than 20, diastolic more than 10, or increase in heart rate more than 30 as well. And how do we check orthostatic? So you want to have them lying down, and then you check it once, and then you stand them up, and then you check it again. There's no need to do an intermediate level where you like set them up and check in between. So it's only lying down and standing. For most patients, you can check it after 1 minute. And for older patients older than 75, you can wait 3 minutes because some of these patients have delayed orthostatic hypotension. So this is like the golden rule. If your patient is here for orthostatic hypotension or syncope, you should be doing your own orthostatics. And I love this tweet from one of the hospitalists in Houston. He's like, "It's quicker for you to check your orthostatics than to request it, then make a note to follow up on the results, then open the chart later, see if it's done, then message the nurse and see, hey, did you do it? And you don't know if the technique was done, how much did they wait, did the patient have symptoms? So golden rule, always do your own orthostatic, especially if that's the chief complaint of the patient. Obviously, it can be hard if you're in a trauma bay. It's like harder. The patient's connected to 10 things. But if that's the chief complaint, or let's say you're following up day one on orthostatic syncope, the first thing you want to do is check your own orthostatics. And I do this every time I walk in the room. I talk to the patient and then I take a picture of their vitals, I check their blood pressure, take a picture of it, and then have them stand, put a timer on my watch, and just have them stand there. And then I check it again. And it's the most efficient way more efficient than asking the nursing to do it or putting in an order. And it's actually, it doesn't take that much time. It takes less than 5 minutes, to be honest. And the patients love it that you're spending time with them. They're really, really appreciative that you're spending some of your time checking it yourself. So, what are the causes of orthostatic hypotension? So, going to the causes. So, the first layer, the first thing to think of is hypovolemia. So, is the patient having diarrhea? Are they vomiting? Are they not eating? Are they taking too much diuretic? So, loss of volume. The second thing you want to think of, like Alison mentioned, is medications. So alpha blockers, mirtazapine, trazodone, amitriptyline, blood pressure meds, and then after that you go to the rarer causes. So early shock, like sepsis, a PE, a new MI, adrenal insufficiency, and then dysautonomia. But in this case, the next best step. So I agree, reviewing meds. But the other thing you want to do is actually uh, look at the first two things. It's very common, hypovolemia, meds. So check their meds and give them fluids. So a lot of times, especially if they have a reason to be orthostatic, you want to start with like 2 liters LR. And I feel like there's a lot of myths around fluids. Uh, if a patient has heart failure, it does not mean you can't give them fluids, especially if they're over diuresed, right? So I feel like sometimes people like hesitate to give fluids. If your patient is orthostatic, your first step should be to give 2 liters LR. Even if they have heart failure, if you think their volume down, they need fluids. So I just do 2 liters LR. The timing of the fluids, like if it's given over 1 hour, over 2 minutes, or sorry, over 2 hours or 30 minutes, or how fast do you give fluids to patients with heart failure? It's not really like based on like evidence that if you give it too quickly in patients with heart failure, they get like flooded. I don't think that's evidence based. I tried to look for the literature. I could not find anything about it. I asked my colleagues at other hospitals. They said like it's just like an urban myth. I'm not sure if it's like based on actual evidence. I usually end up giving like 2 liters over 2 hours just for like the nursing staff. So they're not like too stressed about it, but there's no issues with giving them fluids. And that should be on day one, someone is orthostatic, you need to see if they're hypovolemic. And if they are hypovolemic, adjust their meds and give them fluids. And before we go on to the next slide, I'll just pause for questions. All right, so we'll keep going. Why 2 liters instead of one? I think usually like their chief complaint is orthostatic hypotension. Uh, so and then if we go back to the causes of orthostatic hypotension, the most common cause is going to be hypovolemia. So on day one, I want to confidently say, is this hypovolemia or not? I don't want to come day one and say, is this hypovolemia? And then if I give them a liter and then come back the next day and they're still orthostatic, I'm not going to be sure if there was it a hypovolemia, was it something else? Did I give them enough fluids? So I want to like adequately resuscitate them so that on day two, if they're still orthostatic, I'm like, okay, do I need to think of something else? So I give the 2 liters to be confident enough that they're sufficiently resuscitated before I can like move on to the other etiologies. So like 2 to 3 liters will make me like, okay, peace of mind. Like, okay, I've exonerated hypovolemia as a cause of orthostatic hypotension. That's a really good question. All right, so we were saying that these were the causes, like hypovolemia meds, and then all these other etiologies like early shock, adrenal insufficiency, dysautonomia. Uh, is there a way for us to know, like early on, if it's like hypovolemia or is this dysautonomia? So the trick is that if you're hypovolemic, your heart rate should go up. And if you have dysautonomia, your heart rate usually does not go up. And they actually went and measured this. They were like, oh, in patients whose heart rate goes up a lot, when they stand up, it's probably hypovolemia. Like if their heart rate goes up and their blood pressure drops, then it's hypovolemia. If their heart rate is the same, but their blood pressure drops, they probably have a component of dysautonomia, which is like a form of neuropathy for the most part. So for the 85-year-old who had a fall while in a hot shower, I think the things we would do is EKG, we said for almost everyone, head imaging plus minus, like did they fall, did they not fall? Carotid ultrasound, we said no focal deficit, then probably not, unless we heard a bruit. EEG, probably not. Telemetry plus minus. Orthostatics, like definitely. Echo is a no. CTP, no. Holter loop, no. And we thought orthostatic. Uh, Case two is also a case that I had on wards. 22-year-old who collapses while performing a cartwheel on stage. So what is the next best step? And I'll pause there if somebody wants to answer or put in the chat. Awesome. We hear EKG. EKG, tele. And we hear maybe an echo. All right. So going towards the third bucket, which is like cardiogenic syncope. So when to suspect cardiogenic syncope? So these are the red flags you always want to look out for. So if somebody had syncope while they're exerting themselves or while they're like supine, you want to think of like, oh, like if you were just lying down and then had a syncope, did you have an arrhythmia or do you have a heart attack? What was going on? No prodromes. If you suddenly collapse, if you had palpitations, if you have structural heart disease, if you have a history of heart disease, and then if you have a family history of sudden cardiac death. So when should we obtain an echo in syncope? So obtaining an echo in syncope is one of those things we do for no reason as well. So you only want to get it if they have a significant cardiac history and no recent echo. And the exam suggests structural heart disease or new CHF. So you hear a new murmur, you see signs of CHF. An abnormal EKG is one. An elevated troponin is another one. Or if you suspect like cardiogenic syncope and you don't have like a recent echo. So if you think about it, like why are we getting an echo? Are we ruling out like aortic stenosis? Because that's really, really rare. It's not a really common cause of syncope. So CHF on its own, like we see a lot of patients with CHF, so on CHF alone should not cause syncope unless you're in shock. Unless you see like other symptoms of cardiogenic shock, in which case you should be thinking of other things as well. So the other question is, when do we get like a telemetry Holter monitoring in syncope? So it's mostly if you suspect this is cardiogenic. So are you thinking this is cardiogenic? And then do you have a CHF history and with no alternative etiology for the syncope? So for this lady who collapsed while performing a cartwheel, would you all get a CTPE? Would you get a Holter? Yes or no?
If she's healthy and doesn't, have any reason that a D-dimer can't be done, I probably would dimer her first before exposing her to contrast. But that would be something that you could consider, though, like based on the risk factors, I guess, with the history, because that would potentially cause her to syncopize, right?
Yeah, I love that. And what's your vote on Holter monitor?
Well, I guess that do you guys? I never order any halters actually, and within the hospital. Maybe that's something that you guys do more on day shift, or just put them on telly. But I
Yeah,
don't.
it's usually at discharge.
Okay, I guess that would depend on what you see, like the workup that you get while they're in the hospital. You could determine if they need a halter,
Yeah, yeah,
on it.
yeah. So it's very much like similar to what we're saying. Do we think this is cardiogenic or not? So would I get an EKG? Everybody gets an EKG. Head imaging, again, only if there's like significant focal deficits or she's on a blood thinner. Carotid ultrasound, we just said no. EEG also no. Telemetry, so that's a definite. Orthostatics, everybody gets them. Echoes, in this case, yes. So we think this is cardiogenic syncope, high risk, yes. And then Holter is like, yeah, if the workup was entirely negative and you're thinking, could this be cardiogenic? It's exertional, then yes, you would get it at discharge. And then you would think this is a cardiogenic syncope. So in this case, the patient turned out to have hypertrophic cardiomyopathy. She was like doing the cartwheel on stage, and like we saw it on video. And we did end up doing like a echo, cardiac MRI, and all of the things, and ended up having hypertrophic cardiomyopathy. So we have, I think maybe our last case. So patient, 77-year-old, had syncope when getting out of bed at night. We got the orthostatic blood pressures, and he was orthostatic. We gave him 2 liters of fluids. He's not on any antihypertensives, and then he's still orthostatic. So what would you all do next? All right. So we see in the chat people want to think about like, is this early shock? I love that. And someone is saying check for infection. So check to make sure, is this like an infectious cause? Are they having early shock causing hypotension? I love it. Any other causes of shock you want to check for?
I guess I'd like to talk a little bit more about the autonomic. I don't know. I'm searching my brain and it's not coming to me.
Yeah. We will get to that in like 5 minutes.
Okay.
Um, you can get a CBC. Could potentially be like a GI bleed.
Yeah. So we're hearing about like, could this be like hemorrhagic shock, other etiologies? Awesome. And I think the thing that I was alluding to is, could this be a PE as well? So let me uh, actually let me pause just for a second. And I'm gonna share the shock schema just quickly so you all can see what I'm talking about. Awesome. So this is like the shock differential diagnosis, and it's very like a lot of times people will go through it with you, like these are all the causes of shock. But one super easy way to remember this is the word shock spells out the cause of shock. So if you think of S as in septic, H as in hemorrhagic hypovolemic, O as in obstructive, and C as in cardiogenic, it spells out shock. So every time a patient is hypotensive, I go through this checklist like one by one. Is this septic, like you all said, through blood infection? Is this hemorrhagic? Check a CBC. Is this hypovolemic? Do we have like a obvious loss? And then obstructive, are they having a PE? And then cardiogenic, are they cold? Are they like not perfusing their extremities? Do they have low EF, etc. So this is a really, really quick way to remember it, and I'll share this in the chat as well. Awesome. So when should we consider like a PE and syncope? So about 1% of patients with syncope have PE, which is like 1 out of 100. 50% of patients with PE don't have tachycardia at rest. So we think of PE as like, okay, they don't have tachycardia, so they don't have a PE. In reality, it's really tricky because if it's a big PE, it will definitely cause tachycardia. But if it's a small PE, then they might not even have tachycardia. So when should we obtain a CTPE in syncope? So usually it's like in this case, you don't have any other alternative. The patient is neither low risk and they're not very high risk, like the second patient who was like potentially cardiogenic. You're like, okay, they're intermediate risk, they need to be hospitalized, and we need to find an etiology for this. If somebody has persistent orthostatic hypotension, because we're thinking, oh, is this early shock? And then a lot of times you don't necessarily need to start with a CTPE. You can consider getting like a D dimer. So you can potentially, like Erica was saying, could we get a D dimer first? And then, okay, if it's positive, then you can consider a CTPE after that. And you can get like an age adjusted D dimer. And that's, it's called the years scale. You can get it on MD-Calc, and that calculates your D dimer for age. Okay. So in this case, we ended up getting a CTPE, which showed a pulmonary embolism. So going back to the causes of orthostatic hypotension and dysautonomia, I'm just going to pull up a slide quickly. So what does dysautonomia mean? So in order for your so usually when you stand up, blood pools in your legs. The nerves in your leg the nerves in your heart notice that there's less fluid coming to it. That sends a message to your nerves to increase the sympathetic tone. The sympathetic tone goes to your heart and to your blood vessels. Your blood vessels have to constrict, your heart has to pump faster, and then your blood pressure goes up. So if you notice, there's like so many layers to all this process. Like first, when you stand up, your blood pools. What if the nerve is not detecting, like the nerve that's supplying your artery is not detecting that your blood pressure is going low? So any cause of neuropathy can cause dysautonomia, which means you can have orthostatic hypotension. Any cause of severe infiltrative heart disease. So if you have like amyloidosis, that can cause it. And then even brain disease. So a lot of times you see patients with Parkinson's, their brain, the part of the brain that understands that your blood pressure is becoming low so that you go back up again, is not working. So you see patients with Parkinson's get really, really bad orthostatic hypotension, for example. And in which case the treatment would be like compression stockings, abdominal binder, because the nerves are not working to respond to this low blood pressure. And sometimes you can get it from alcoholic neuropathies or diabetic neuropathies. I'm gonna pause there. If anybody has any question, you can go for it now. All right. So So let's recap everything we talked about today in Syncope. So let's talk about the indications for all these tests. So history and EKG is always. Orthostatic, almost always. So if your patient can walk, they need orthostatics if they're coming in for syncope. Head imaging is not indicated for routine syncope. So usually you want to check for either consequences of a fall or it's a syncope mimic. Like, did they have a stroke or are they head trauma on anticoagulation, focal deficit, or persistent encephalopathy? But otherwise, should not be part of routine syncope workup. Carotid ultrasound. So focal deficit, a stroke, or a carotid bruit. EEG. If you're concerned about continuous seizures, like somebody is still very confused, you ruled out delirium, you ruled out all the other things, then maybe you get an EEG, but it's not part of syncope workup. And because if you're concerned for a seizure, it would be like a clinical diagnosis. Telemetry, it's mostly if you're concerned for cardiogenic syncope. You might have a lower threshold in the hospital to get it if you're like, oh, they're higher risk. They have EKG abnormalities, you're worried about cardiogenic, then you can get that. Echo, only if you're concerned for cardiogenic syncope and they don't have a recent echo. So I see this a lot, like the ER comes in and the ER orders an echo for syncope, and then they've had an echo in the past, their EKG is normal, then they don't need an echo, and you're empowered to cancel it because you can reference the things we do for no reason paper, and it only says only get an echo if you're like, oh, this is cardiogenic, if they have an abnormal trope. Otherwise, there's really, for the most part, no need for echo for syncope. Your history is going to be your strongest friend in this scenario. CTPE, medium to high risk syncope with no alternative etiology. So you're not sure what's going on. You can consider a D-dimer first. And then Holter loop will be at discharge, whereas like concern for cardiogenic syncope as well. Erica.
I have a question about the echo because one of the tests that I frequently order a lot on Team W is for these elderly demented patients that come in, after a ground level fall. You can't really get a history. It might have been an unwitnessed fall. Most cases, it's an unwitnessed fall where someone didn't observe them to trip or something like that. But you can't get a history from them, and so I often find myself writing suspected syncope, unable to obtain history from patient. And I feel like I order a lot of echoes. How would you advise on managing those type of patients with regards to trying to limit the amount of echoes that are, ordered, unnecessarily?
Yeah, that's a really good question. So usually, if you're getting an echo, what are you looking for? So the things you want to be looking for, like how will an echo abnormality cause syncope? So usually it's only if you have like really, really bad aortic stenosis or like a really, really low EF, like the EF is 10. So usually what I recommend is that if you're like if you check their extremities, they're not in cardiogenic shock, they're not cold, they don't have volume overload, and you have like an echo that's been done recently, then you're like, okay, there's no real like indication for it, like the echo. Uh, let's say you have an elevated trope, and then you're like, why should I get an echo or not? The biggest reason why you would get an echo in that scenario is to rule out like a focal wall motion abnormality. So you're like, oh, this could be an MI. So this brings up to the next point is, when would you postpone surgery to get an echo, or when should be like a emergent echo? So the answer is almost never. So the only reason you would postpone like an orthopedic surgery is literally if you're having an MI. Because if you're volume overloaded, they would do it anyway because it's an urgent surgery. Even though you might diurese them, but they would do it anyway. The echo is not going to change anything. The only reason that it would change management is like if they're actively having an MI and then they become really, really high risk. So that's the strongest indication. If they have like recent echo, then I definitely would not order again. If they have like no echo at all, uh, I think that I don't think it will like change management. Like if I saw them during the day, I wouldn't order an echo, unless like anesthesia team feel very strongly about getting an echo for that reason. What are your thoughts about that?
Now that's really helpful. The only other question I have to ask is, how recent would the echo need to be? Like, say, does it need to be within a year, or can it go a little bit longer like that, maybe up to 3 years? Um, let's say they had an echo that may have, it didn't show any like valvular abnormalities, but maybe showed some diastolic dysfunction, but nothing significant on an echo within the last 3 years. Would that be sufficient to kind of justify that this may not have been a syncope, a cardiogenic syncope?
Yeah, so if it is a cardiogenic syncope, it's probably going to be an arrhythmia, and it's not going to be because of aortic stenosis. You know what I mean? Like
Right.
it could still be cardiogenic. You just won't see it on the echo. So I think there is no there's no like magical number. Like there's no number where we say, oh, this is like 100% like I'm 100% safe. But I think in my practice, I would just pick like 2 years is like reasonable. But I don't think there's like a magical number. I think it's mostly like 2 years. I check their extremities. Are they overloaded? Are they cold? And then I just pulled this up from my pre-op medicine notes. And it just says like most CTEs will not change management pre-op. If they're volume overloaded, then they need to be diuresed regardless of the EF. So if you have a recent echo, you're probably good. You would repeat it if they have heart failure or they haven't had a recent echo, then sure, you would repeat it. And then if they have heart failure, it might affect the anesthesia type, but anesthesia can do their own focus as well. So I think if they have normal trope and echo within the last 2 years, I think you're good for the most part. Not even normal trope. If they have like a flat trope, you're not worried about MI,
Right.
then you're probably good.
Okay, thank you.
Any other questions? All right. So the final bonus slide was also from the same influencer who was saying that we should almost never get a UTI urinalysis for patients who are older and confused. And I think that's very reasonable. It's just that like if someone has syncope, uh, them having UTI will not necessarily cause them to have syncope unless they're having like early shock. Like you're not going to just have a urine infection and then have syncope. You might be delirious because of like a disseminated infection, but so usually if they don't have like suprapubic tenderness, if they don't have dysuria, and even if they're confused, then I just check for suprapubic tenderness. And if they don't have that, then there's really no reason to check a UA. And the influencer here is throwing the UAs in the trash. So I'm gonna as always, I made this talk into a dot phrase. So you can feel free to like copy this to make it easier to always like go like systematically to the cause of syncope. Uh, and then to recap everything we talked about. And I'll share the slides as well afterwards for all the uh, indications for what we should or should not do as part of syncope. And I'll just pause there for questions. And then if you have any feedback, please feel free to fill it in this QR code.